Thank you, Chair. My question, I just want to build very briefly on the maternity discussions. I've had conversations with constituents and women who've had very difficult situations with miscarriages and stillbirths. And one of the things that comes out of that is that sometimes there's a concern about negligence and the issues we talked about today, but other times they're not quite sure. And one of the things that really came through was the lack of mental health support that they've had afterwards. And I just wonder when looking at the sort of looking at policies and so on, how much beyond the financial aspects of litigation and beyond the learnings, which are absolutely critical, has mental health been support and a better process really to help people deal with what can be incredibly traumatic life experiences? Has that been looked at, and is that something that will be in the future?
Yeah, so certainly for where there's been a bereavement, so a stillbirth or a neonatal death, we've now got bereavement midwives, which are midwives that specialised in looking after mums, parents, going through that process, either if they know that a bereavement's likely to happen, or if something happens unexpected. And they spend a lot of time at the time of a stillbirth or a neonatal death, but then a considerable period afterwards. But we don't have enough of them, and that is something I've been to King's College to meet with the team there, and they do an amazing work. And they say to me the difference of having that specialist, midwives are very specialist anyway, but having that specialist midwife who can look after the family as a whole at such a difficult time, whether that's happened from natural causes or whether there has been a clinical negligence incident, does make a difference. So I'm very keen to look at how we can support midwives. They're very keen to take on some of this extra training and role, and I'm very keen to look at how we can support them in doing that.
That's very good to hear.
I would just add that we were discussing earlier that as well as looking at cost data and outcomes data and safety data, we need to consider that patient experience, as it were, and family and carer experience is one of the key things we have to have in our mind when we look at different options for reform. So I would very much agree with the point you were raising.
Absolutely. I mean, I think one of the things that it also comes through is as you pointed out just there, the support given to families, because when somebody goes through an awful crisis like this or a life-changing moment, it's often the families that they look to for support. And again, I don't know how much we're equipping families with the right information to know how to support them or where to go to for support from bereavement midwives, for example. Just on the bereavement midwives, I appreciate you might not have the numbers right now, but is there a way that we could get an update on how many there are across the NHS currently, and what the plans might be in terms of projecting for training for that?
Yeah, I could certainly send the committee the figures. They've kind of grown up historically, and so some units have them because they've got midwives who've wanted to take on the training, and the units have been very keen to support them in developing that role. And some units don't have access to them at all. So we can get you the figures, and but there isn't. There is more work that needs to be done to support midwives who are keen to take up those roles.
Thank you. And may I just ask, just on the international view of this, we had evidence previously from international experts about what's happening around the world. Have you, through your work, seen any exemplar examples that you would like to adopt here, or policies that you think actually we could be learning from what's going on elsewhere in other countries?
I think it is difficult, and that's why I think we need to look at all the options in the round, because it's very difficult to make international comparisons. We've got a very different healthcare system to many countries in the world. We've got a very different legal system. The kind of health and social care support that patients have varies too. So there's an assumption that you can just lift up and slot in a different system to the UK, but that may not necessarily work. We pay full compensation at the moment as part of our system. In some of the no-fault areas or countries, they have a limit to £1 million, and is that something we want to be at? I'm not saying whether we do or we don't, but we need to look at all those options. It's that there are complexities that, for Japan, for example, which was raised, I think they introduced some safety pieces on safety work at the same time that they introduce their changes to their legal framework. And so it's actually quite difficult to decipher which has made the biggest difference, or if there's been any interconnectivity at all. So this is why we want to do a proper piece of work on this, to make sure that if we do change things, that we change them and they make a better impact for patients.
Did you want to come in as well?
I mean, I would add that it is difficult to compare the schemes, and I've colleagues from Sweden, for example, talking to them recently and seeking to understand the relationship between the level of claims that they pay out and then the degree of support that's available through the wider health and social security system in Sweden. It makes it harder to sort of translate the lessons, but we're very committed to international learning as part of this exercise.
Thank you. And one very final question, if I may. You used the word, Minister, just now, interconnectivity, and one of the other aspects that I've heard firsthand is the lack of interconnectivity in terms of lessons learnt. So somebody may go through a bereavement, you might have litigation or complaints being made, and that might be made with a hospital, but actually the GP then doesn't know about that, or other parts of the system. And that can often make it very difficult for somebody already going through a traumatic experience to have to relive that, explaining it to other parts of the system. And especially when you do have this sort of wall go up with lawyers and everybody not saying anything, it makes it even harder. I just wondered again, is that something that's been looked at in terms of how data is shared, but not just quantitative data, not just the numbers, but the qualitative data in terms of the actual human stories and the positions that people find themselves in?
Yeah, so there is a number of ways that best practice it can be shared. I mean, obviously we have nice guidelines in clinical areas. So I was thinking of a Westminster Hall debate I did a couple of weeks ago on sickle cell, where MPs were describing some of their constituents had hours-long waits for pain control. And actually the NICE guidelines is very clear that they should be getting pain control. I think it's within the hour. I could be wrong, but I think that's the NICE guidelines for sickle cell. But that should be, where there is best practice guidelines, that should be being implemented. And CQC will look, when they're doing their inspections, at areas like that. But they can't look at every single NICE guideline when they're doing an inspection. But there are measures in place to share best practice, but we do need to do better.
Yeah.
There's no doubt about that.
I think you raised an important point there about specifically around the role of colleagues in primary care in terms of supporting their patients, and indeed the chair and I were discussing in another context that the power of personalised care in general practice and the difference that makes. So I think it's something for us to take away as well.
Thank you, Chair.
Thank you.